All right. Good morning, everyone. Thanks for being here, and we want to thank Teresa and her team with Behavioral Health Billing Solutions for pulling this together and for inviting us. I think there's a great deal of information today. I think it's a good program. We're happy to provide continuing education and CPEs for this, so please do make sure that you've signed in out front and we'll get you those certificates. I know there was a question raised around nursing CEUs. For the nurses in the room who are interested in CEUs, be sure to sign up. You can use the Counselor Social Worker Board. The social work credential will be reciprocal with the nursing board. So just know that for the information. Just a little bit to talk about the Ohio Council. Since I know many of you in this room are familiar with our organization, you're members of the Ohio Council, we thank you for that. But for those of you that aren't, we wanted to let you know who we are and what we do. We are a statewide trade and advocacy organization. We represent over 140 community behavioral health, addiction and prevention treatment providers and family service organizations statewide. Our members provide about 70% of the covered behavioral health services in the state of Ohio. We would encourage any of you who are not currently members, large or small, to please consider joining us. I've got information in your packet on our membership, as well as we've got some information over there, and there's candy. So if you get to the point that you need a little sugar fix, please help yourself to the candy. That is an Ohio Council staple for any of you who know when you come to our meetings, we always have candy available. What we do, just for those of you who don't know, we have kind of three main services that we offer. We do public policy work, and that is the majority of what we do, meaning we're working on the policies, the programs with the state agencies, with all of the various funders around making sure that the services that you are able to provide meet the needs of the patients and the consumers and the families where you work. The second thing we do is we offer a lot of technical assistance. So the training and the materials that you will receive through this is kind of a presentation I've been doing for a while, for a little over a year. It will feel like drinking from a fire hose because the amount of information that I've put together for you. Some of you in the room are shaking your head. Yep, it will be. We do it this way so that you get the information. This is a presentation I can do in 90 minutes. It's also a presentation I can do in 8 hours. So we're going to hit the highlights of it today. You'll have lots of questions. That's kind of the intent, but you'll also get the information so you have it available to use back in your shops. And then the final thing we do is we offer member services. So we have a number of services that we provide to help you as businesses operate. So those are things that are available if you're a member of the council. So to step back and think about BH redesign, I don't like to use the forest for the trees analogy because I think that's too simple. This actually is what I think about when we step up. If you stepped back and looked at BH redesign, what it would look like from the top. It's been a long process. It is complex and it is winding, and you never know which one of those on-ramps or exit ramps that you're on today. So I think that's just a good summary of what we're looking at. These are the things we're going to cover today. We're going to talk about the policy because while I'm a social worker and I've done clinical work, I've been doing public policy work for now at the Ohio Council for almost 14 years. And I was a clinician working in the field for about 15 before that. So we won't talk about how many years that adds up to. So we're going to start with the policy, then we're going to talk about practice change, working with managed care, and then we've got some data and numbers on how we are progressing. If you are not familiar with the Behavioral Health Redesign website, you should be. If you are not checking it on a weekly basis, you should be. There is new information being posted, particularly in the Managed Care Resource Guide. That document is work that we started with the MyCare Ohio implementation, where each of the managed care plans have agreed to work together to answer a specific set of questions. We have updated that document. We have kept it current. The managed care plans are graciously and willingly sharing updated information almost on a weekly basis. So that's on this website. Make sure that you are checking that website on a regular basis because there's good information there. There's good reminders of information. When you're running into problems and you're not sure what to do, go check that site. So I use this slide because anytime you've seen anyone present from the Department of Medicaid, Department of Mental Health and Addiction Services, the Office of Health Transformation, at any public hearing, you get a reminder of all of the things that are the Kasich administration legacy. This is what we've changed since 2012. You'll notice that there's a big gap between elevation, expansion, which was critically important to behavioral health, and then the modernization, which is the word that's been used to describe the coding change, and then the accelerated timeline for the transition into managed care. Whether or not we were ready for movement to managed care was a big question, frankly, because of where we were politically in the political spectrum and where we were at the end of an administration. A lot of the decision-making was about wrapping up a project. So that's important to understand, because if you look at the timeline, we went from 2014 to 2018, because who knew that healthcare was complicated, right? Who knew that our behavioral health redesign was going to take a lot of the effort that it did? So that's where we are. That's the amount of change. And if you'll feel tired and exhausted and completely overwhelmed, it's because we've been doing change since 2012. I want to talk a minute about rethinking the behavioral health and to step back and make sure folks understand and look at how the structure changed. Because this is really a fundamental change for all of us who've worked in the community behavioral health system and our reliance on the Department of Mental Health and Addiction Services. With the implementation of BH Redesign, this was a structural change, and it's a fairly substantial change. So you still have national accreditation. It's the gold standard. It's the industry standard. If you're working with insurance companies, not just in Medicaid, but if you're looking to expand your business into commercial markets, which you all should be, this is what they're going to be looking for. This gives you opportunities. This is quality care. This is a focus on quality improvement. This is where we're looking for in terms of customer satisfaction, best practice. Mental health and addiction services, their certification process is still required if you're going to be a Medicaid provider. Starting in next June, anyone doing addiction services will be required to have mental health and addiction certification. These are minimum standards that are intended to protect health and safety and basic clinical service delivery. They are now agnostic to payer. That is a very important point to understand. So regardless of who the payer is, mental health certification is about those minimum standards. And if you're nationally accredited, they will recognize that as meeting the requirements for those standards. Then you come down to the payer requirements, and what you see here is this is now variable. So you have mental ODM coverage and limitations that requires mental health and addiction services certification. It defines the coverage, the services, and the documentation requirements. We're going to touch on that in a minute. You've got your Addon boards and your state and local dollars that flow through the Department of Mental Health and Addiction Services. Again, requires MHAS certification. It can have different arrangements based on what the contracts say with your Addon board, also with the department in terms of how they put grants and resources out. And then finally, you have commercial insurance, where they're not necessarily looking for mental health certification, but they will be looking for national accreditation, and your negotiation with them will be based on your contract. So understanding contracting and how contracting works is a skill set that you will need to have, and it will work differently than what you've been accustomed to in working with Addon boards. That is something that we have to really come to terms with as a system and as a group of provider networks in terms of how to look at and think about contracting. From a rules perspective, because in one of my former lives, I was a compliance officer, so rules are really important to me. They should be important to you because they tell you what the expectation is. This is where you will find one of the most substantial changes. So on the first side of the screen, you see the MHAS rules, and those are what you're comfortable with. Those are what you're most familiar with. Those are required for certification. What's most important for you as a Medicaid provider is the rules on the far side of the screen. Making sure that you understand what those ODM rules say. Those rules in Chapter 5160-27 is where you will find the Community Behavioral Health Services. However, you also need to know what's in Chapter 5160-805, which is where your licensed practitioner coverage is. And if you're doing medical services, you need to know what's in 5160 Chapter 4, because that's where the rules are that govern those services. This is something that is different with Redesign. Since January, I still continue to get calls. Well, the mental health rules say this, and we need to call the Department of Mental Health and Addiction Services regarding a Medicaid issue. No. When they redid these rules, they broke that connection. The only mental health and addiction services rule that is referenced in the Medicaid rules as the governing regulation is the definition of CPST and the requirements around interactive video conferencing. So those two rules in the MHAS section of the chapter move over and are referenced in there as the governing definitions. For everything else related to Medicaid, it's all in the Medicaid rules. That's a really significant change for most of us in this room. And then we have this other fun thing. Medicaid insisted on creating a provider manual. It was intended to be helpful. I have a bias against the provider manual. I will be very upfront about it, and I'm going to tell you why. The provider manual is not consistent with what's in the rules. It expands on rules and goes beyond what the limitations that are stated are in the rules. That's a problem. Make sure you've read page 7 of that provider manual, which is the legal disclaimer. That legal disclaimer says that document is for education and training purposes only. It says that if there is any conflict with the administrative rule, that the administrative rule supersedes. It also says that it is not intended to expand on what's in the administrative rule or the revised code. However, it does. Here's the challenges that creates, and it creates challenges for all of our partners at the managed care plans. The MIT system, when we started in January, was set up based on what's in that manual. When the managed care plans went through readiness review, they were told and held accountable to what's in the manual. So you automatically have inconsistencies and challenges. The managed care plans have inconsistencies and challenges. But their payer, their contractor, says, follow this. So that's where we are. We all share this challenge, and it's one that we're having to work through, and it's one that's not going away anytime soon. The other challenge is it hasn't been updated since January. Actually, it was in January. There are a couple things that are missing. Anybody that's doing withdrawal management services knows that there was a code that was changed on December 26th. Merry Christmas. None of the plans got it because it wasn't in the provider manual. It was in a MITS that came out on January 26th, or December 26th. So these are the kinds of things that we're going to continue to use, but it's important to understand that that's what's happening with the provider manual. So I want to just, I'm outlining the rules here or the new services because I think it's important to understand the differences between how the mental health services were structured and how the SUD services were structured. One of the things that we did is we did attempt to align services with industry standards. I will say that as a sorta, because it only happened part of the time. It introduced a lot of complexity, and partly because in aligning, we're using all of the CPT codes the same way that we're using them in mental health as we're using them in drug and alcohol. That was a big change. I think we've finally gotten there to people understand when you're billing individual counseling, you use the same code, whether it's in mental health or SUD. That was also a substantial change that took a lot of, what? No, it's always been separate. Nope. On this side, we put it together. The individual reporting and rendering practitioner model has created a lot of challenges. I think it's something that can be useful. I think we've got some fixes we need to make to it. And then the other thing we did, we went to a tiered pricing based on the educational level of the practitioner. That was also a change. So going from team-based care to this type of arrangement, in many estimations for us, when you're talking about the national scene, where you're moving to outcomes-based payment, you're moving to value-based purchasing, it's all about outcomes. Going from a team-based model of care to an individual practitioner model of care was a step backwards. But that's what the department decided they wanted to do from a pricing standpoint. So understand that's where it's coming from. It's a pricing strategy. I get a lot of questions about this last part, this rehab services, and the TBS service in particular. How many of you have asked, I don't understand why TBS as a service can't be billed by a licensed practitioner? Well, this is one of the illogical natures of BH redesign. This is what the Medicaid state plan looks like. If you understand that the Medicaid rehab option is how we finance and structure and get authority for the services that we provide, you've got authority for your clinical services under other licensed practitioner we talked about a minute ago. You've got authority for your mental health for your medical services under the general medical benefit offered under Medicaid. Under rehab option, we have 3 services in our state plan. You have therapeutic behavioral service, which is from the state's perspective an umbrella. You have PSR, and then they had CPST, which they did not make any changes to. Under the umbrella of therapeutic behavioral service, it's important to understand that the authority for these 5 services are embedded under TBS. If you've ever wondered why the codes are so consistent related to the definition, if you look up the actual definition of the code, many of them say TBS. It's because under this umbrella in the state plan, we put 5 services. It has inextricably complicated the billing for mental health services. It's why you're experiencing some of the challenges with billing that you're experiencing, particularly for TBS group services and individual TBS services. It also makes you question why we've been told under TBS it can only be unlicensed practitioners. Because from a state plan perspective, that's not true. I've got all kinds of licensed practitioners under ACT. In IHBT, I'm only allowed to have licensed practitioners. Under therapeutic group service, which is a code word for day treatment, because to add it as a definition of day treatment, they would have had to amend the state plan. You've got all kinds of licensed practitioners, and then we put nursing under TBS. So this is structurally why you're experiencing some of the challenges that you are. I just think it's important to understand that, and I don't think we've spent enough time talking about that publicly for folks to really understand why we have the complexity on the mental health billing side that we do. Psychosocial rehab is a much narrower service. It is only those people who have lower level licenses, and then we threw LPNs on there because we decided from a policy perspective that they had a scope of practice that was similar to this. The other thing I will say is in doing some of this policy work, what we came to understand, if you're familiar with the DD billing system and you understand homemaker personal care and you understand how we structure those services, this setup for TBS and PSR, particularly on the individual service side, starts to look and feel a lot more like the types of services you would see in the DD system, in a waiver, or doing homemaker personal care. And that was, I think, some of the influence of the consultants that we had working on it. So I just think it's important to understand this. On the SUD side, completely different structure. On the SUD side, it's all focused on the ASAM criteria, and it's organized differently by level of care, by intensity of service, and by needs of the services. So you'll see the services line up very differently than they do on the mental health side. It looks like there's a lot more services. It's just that they're organized and recognized differently. The other thing that we'll talk about in a minute is withdrawal management. Withdrawal management is a service that can actually be plugged into any level of care. So that's a different way of organizing services as well. Documentation requirements. If you take nothing away from this, take this one down as your compliance person saying, please understand this. From your documentation requirements, it is no longer following the progress note rule under the MHAS certification. If you are not familiar with 5160-805 paragraph F, you need to be. Because every single Medicaid rule for coverage and payments points to this section for documentation. It adds requirements that are not in the MHAS certification rule. That is really important, and it is a big change. Practitioner enrollment. I was so happy that so many people raised their hands around understanding the NPI. This was a fundamental change. Making sure that folks understand that when you are thinking about this, that you have people coming in, they have an NPI, you have to have an NPI on every claim. Practitioner enrollment with Medicaid and the affiliation with your agencies. And if you are a mental health agency, a mental health NPI and an SUD NPI, it's affiliation with both. The recommended time to do that affiliation is at enrollment. There are ways you can change it, and you can go in through the provider side, the provider portal in MITS to make those changes. Even though we've moved to managed care, you still have to do practitioner enrollment with MITS. It's a federal requirement under the ACA that every practitioner still enroll with the single state Medicaid agency. So that's why this exists. The QMHS enrollment was not structured in a way that's been most helpful. In their infinite wisdom, and we suggested this was not the right path to go, they created two categories. There's the QMHS, which is your unlicensed less than 3 years, your bachelor's degreed person, and your master's degree person. There's no tracking for what educational level. They just rolled them as a QMHS. That's become a problem for all of our managed care partners in getting their credentialing file set up because they don't have the information. The QMHS plus 3 is only for those people that you are qualifying based on having 3 years of experience. Your agency gets to define how they meet the 3 years of experience. You don't have to share that with Medicaid. You just have to provide an affidavit that they meet the 3 years of experience. Dual credentialed people. This was a challenge too, because when we looked at it, it was, well, I want to enroll them as, what they primarily do. Nope, that's not how it was structured. Enrollment was structured to credential them with the highest scope, meaning the broadest range first, and then any additional credential second. There is a MITS from 823.18 that you want to be looking at and using and making sure your HR staff know, because that tells you the practitioner enrollment. Question I've started to get, they won't enroll my staff as an 84. Right, 84 is your mental health agency. They're going to enroll your staff as like a 30-set provider type 37. That's a social worker. So your individual clinician will be enrolled in a provider type, and then that provider type gets affiliated with your agency NPI that's either an 84 or a 95, or if you have a medical practice, it's a provider type 20 or 21. It depends on how many different lines of business that you have. There are still required modifiers. Again, there is a supervising, rendering, ordering fields document that is posted on the BH Redesign website that will give you the structure of how this works. For your QMH staff that are still delivering CPS or TBS, you need to make sure you have the HM, HO, and HN plus their NPI. Interestingly, the QMHS plus 3 is optional because it has its own category. Couldn't make it more complicated if we tried.
So you mean we don't have to send a UK?
That's what the documents say.
Can all the MCOs attest to that?
The question is that true from the MCO's perspective? Are you expecting the UK in your billing?
Certain services.
So that's not, so on certain services you're requiring UK? Not according to the supervisor rendering and ordering fields document. But if that's what the plans are doing, that's what we need to understand.
One other thing I wanted to mention, I see a lot of people taking pictures. You're going to get all the slides. Oh, you're going to get all the slides. You're going to get the recording. You're going to get more information that you ever wanted. So feel free to take pictures. You don't have to. Okay.
All right, I'm going to keep rolling because I'm going to run out of time. Dual credentialed staff, making sure that you're using the second modifier. We've given you an example. The example is a nurse. They're going to be primarily enrolled as an RN. If this nurse would be choosing to bill as the LSW for psychotherapy, you would bill with the NPI plus the U4 modifier. So that's just an example of how that works. Also, one of the things that was updated late in the process in, I think, end of June was they did allow the RNs to be registered as also a QMHS. I'm not sure why you would choose to do that, but that is an option. So moving into, it'd be to bill for CPST. Again, I want to talk about nursing, and I would question why you would choose to do that, but okay. This, I think, is really important. This is where there are substantial changes in how we have moved forward. We have to start breaking our legacy of contracts. We have to break the legacy of what we have in our history in working with our Addon boards as being the governing role of what we do. We need to step up and be businesses, and we need to be able to negotiate. We have opportunities for change, and we have to overcome what I kind of consider almost the institutional trauma of learned helplessness in our systems. We have to become business partners. We have to become providers. We have to negotiate. We have a lot of changes and a lot of opportunity. I'm going to roll through these really fast. You'll have questions. You will get all of these slides. The Addon Codes. This is something that's new. It gives you new opportunities. It also helps to document complexity of care when you're talking about some of the patients that you're working with. When you're entering diagnosis codes, this is an aside, it's really important that you put the primary diagnosis code that you're pointing to, but you need to have the other diagnosis codes that that patient has on your claim. Because eventually we're going to get into complexity coding. You're going to get into value-based payment arrangements where they're looking at how sick is the population of people that you're serving compared to the population of people being served in a medical office or in a private practice. Your payment rate arrangements with different plans is going to be dependent upon that. But understanding where these codes come from and not being afraid to use prolonged service when you can, and interactive complexity. And I get a lot of questions about interactive complexity. Oh, it's an audit risk. Oh, we got all these problems with it. I think Sonda will talk about this afternoon. But it's important to understand that this is really about a state of being and not just looking at who's our population and only using it when we have somebody who's outside our baseline. In community behavioral health, our baseline is already beyond what is the typical person that is being seen in many other settings. So not being afraid to use these codes because you're delivering a service that meets those requirements. Assistants and trainees, we get a lot of questions about this one. I'm going to keep going and take questions at the end. We get a lot of questions about assistants, trainees, and CDCAs. You can bill the CPT codes. You can bill under general supervision, or you can bill under direct supervision. If you bill under direct supervision, you do get payment at the rate of the clinical supervisor. However, make sure you understand the requirements in 516805 of direct supervision, because direct supervision is a much higher standard than Medicare Incident 2. You have to see the patient. The supervisor has to see the patient at the first visit. They have to see them at least quarterly face-to-face. They have to review and update the medical record after each patient visit. And then the service reimbursement is then at that supervisor's rate. And then you put the supervising NPI on the claim, and that's how you get the higher payment. It is a much higher standard. You can have an agency policy related to how you do this. The other interesting thing is our most flexible workforce, who can bill either in the CPT code world or in the HCPC world, is this set of practitioners. I will also say the other thing we've learned in this particular set is we do have a gap. And the gap we have is for student trainees who are bachelor's level social workers. So that is a challenge that we're still trying to work through, because one of the requirements in the rule in 5160-2701 is that in order to be qualified as a QMHS, the individual has to be an employee or independent contractor of the organization. Your bachelor's level students are not that. Now, are there ways we can have contracts for employment that are at no cost or low cost? Maybe. I think these are questions that we're all still trying to work through. But we'll be aware that is a gap that we do know is there. Nursing services, one of my favorites. Couple really important things, and this is where understanding what the rule precisely and explicitly says, and then being willing to live in some gray area. Mental health and SUD nursing services include those activities performed within the professional scope of practice by a staff licensed by the Ohio Board of Nursing and intended to address the behavioral and other physical health needs of individuals receiving treatment for psychiatric symptoms or substance use disorders. Let me paraphrase. Anything within the nurse's scope of practice is authorized under this service. I frequently get the question, what am I supposed to do? My nurses can't do assessment. My nurses can't do individual counseling anymore. They can't do group counseling. Nope, not true. It's in their scope of practice. They can't bill individual therapy. They can't bill group psychotherapy. They can't bill assessment. They can bill mental health nursing service all day, every day. So it's a difference in what you bill for versus what they're doing. They're authorized under this rule to do what's in their scope of practice. Now, a couple things that are in the rule that are not consistent with their scope of practice. The Department of Medicaid decided that nurses may provide assessment and group therapy, but LPNs may not. Under their scope of practice, an LPN could actually do a group therapy appointment, but Medicaid has put it in their rule that they're not permitting that. Again, something we have to fix when we have its chance in the future. The ODM rule in this particular set is silent on whether this service has to be delivered face-to-face, to collaterals, or over the phone. I will tell you from doing the policy work that was deliberate and intentional. What this means is if you document the intervention, and the question I get a lot is phone calls. My nurses can't bill for phone calls. The rule doesn't say that. What you write in your progress note is what becomes important. Is the intervention the nurse provided an eligible service? If you document, I called the pharmacy and they're discharging hospital, no, that's not going to be a covered service. If you document, I coordinated discharge planning for this patient by discussing their discharge plan with ABC nurse at XYZ hospital, and we followed up with the pharmacy to make sure they had access to the medications for discharge, that's a billable service. It's no different than the way you document transportation for CPST or TBS or PSR services or SUD case management. So just keep that in your mind and think about that, particularly when you're looking at the differences in the rates between TBS nursing, PSR nursing, SUD nursing, and CPST or targeted case management. The other thing is the ordering. Anytime you bill a nursing service, you do have to have an ordering. There are multiple ways you can get to that ordering prescriber on your claim. This becomes an issue of your own agency risk tolerance. You can do it by having an individual treatment plan signed by the prescriber. You can have a standing order. You can have a blanket order. Probably wouldn't recommend that one to the degree that I would. Or you can have an individual progress note signed by the prescriber, if that includes your treatment plan. This becomes an agency practice, it becomes your preference, and it becomes a level of your own risk tolerance. I've given you some different, the other question we get is you can bill E&M services and nursing services on the same day. This was a long, hard-fought battle to win. The trick is you do have to change your practice from the way we did it before January. Before January, when nursing services were counted in minutes, and then you added the physician or nurse practitioner minutes to it, that is probably not what you want to be doing anymore. The issue is in the EMM code, if you're using information that the nurse gathers as meeting some of your requirements to meet your level of care within the EMM service coding, that time of the nurse cannot be double counted. If you're collecting vitals and presenting history at the beginning of an appointment, and the physician or nurse practitioner is incorporating that in their history and presenting the problem, then that's part of the E&M service. The reason we were successful in adding this is because we know our nurses do so much more, particularly on the back end. They resolve crises. They do a lot of additional extensive counseling. They do many, many more things. That's really important. And we got them to believe that this and understand how critical our nurses are in supporting medication management. Rethinking assessments. This is my favorite thing in the whole program. We have historically been horrible as to how we treat our patients at assessment. I know of no other sector of healthcare where we require them to come in for 4 hours. We spend 2 hours talking to them about signing forms and giving them their rights and asking them about their financials and giving us all kinds of social information. And then they meet with a clinician who spends 2 hours talking to them about their entire history. We never provide a moment of care in that first appointment. We have to do better. We wonder why people don't come back. That's why. So there were major changes here that we need to be taking opportunities because we actually have great opportunities to improve patient engagement. Under the MHAS rule, you're now permitted to do an initial assessment and then have a comprehensive assessment completed within 30 days. That is a game changer. That gives you the ability to say, what is the information I need to make an initial diagnosis, to develop an initial treatment plan, and in that very first session, I can start delivering care. You then can figure out, are there different ways I can collect information? Can I use my CPST staff? Can I use my nursing staff? Can I use some of my paraprofessionals to gather some of that additional history information that then gets incorporated into that assessment document, and then you get a final assessment completed within the 30 days with the final treatment, with your ongoing treatment plan. So we have to start to think again of assessment as a living and ongoing process, and of treatment planning as an ongoing process. Then how you bill it, you've got options. We no longer live in a world of MCSIS that says before you can register a patient, you have to bill an assessment code. You have options. You can continue to bill assessment codes, 90791, 90792. You can also bill individual therapy. If you're doing a brief assessment and you're starting therapy, bill it as therapy. If it goes longer, you go to that 90-minute mark, add prolonged therapy. If they're interactively complex, add interactive complexity. Same thing with new patient E&M. So you've got a new person coming in to see the doctor, you can use a new patient E&M. Now be careful. If they've been seen by your organization within the previous 3 years, they're not new. So understanding those CPT codes are really important. If you're doing same-day access clinics, really be aware of what the NCCI edits are and what your options are in terms of billing assessment, and also being able to see a nurse practitioner or PA in the same day. The question I always get when I talk about this is, well, what if the patient doesn't come back? I don't have the information. If you did a brief assessment and you did an initial treatment plan and you rendered an initial diagnosis, you've done exactly what you need to do. If they don't come back, national accreditation says you have to have policies and procedures that talk about how you collect and do assessment. You have a process for how you're going to gather that. If you're following your procedure for an initial assessment and that ongoing process of collecting the full biopsychosocial, you're fine. You are complying with the rules, because the MHAS rules also say I have 30 days to do a full comprehensive assessment. There's nothing in the Medicaid rules that say thou shalt bill an assessment first. I want to be clear, I am not in any way suggesting that clinically you never do an assessment first. You always clinically do an assessment first. But from a billing perspective, the days of our historical enrollment in the MCSIS system and the requirements by most boards that say you have to bill and document an assessment is not the world we live in today. Group counseling. This is one of the areas in the policy work where we see a major shift. This was one of the most frustrating. For those of you who do SUD services in particular, you know that there's a challenge here. This is an area where it was very clear that there is a bias towards individual therapy. The only code you have available for group counseling on the mental health side is the CPT code. It's an encounter code. It doesn't matter if your group is 30 minutes or your group is 2.5 hours. You get paid the same rate. On the drug and alcohol side, because of the advocacy we were doing in the state budget process last year, because there was a focus on the opiate addiction when we met with Robert Sprague, who was our champion in the budget process last time, we were able to get a little bit in that on the addiction side, you can bill H005 and go back to 15 units if your group exceeds 53 minutes. The difference in terms of what this meant from a rate perspective on the mental health side, it's essentially a 60% rate cut from what you were paid this time last year. On the addiction side, it's a 30% rate cut. Neither are sustainable, but it helped. What we know this is doing is this is creating new gaps in care, particularly on the drug and alcohol side for outpatient therapy, where you've got patients that aren't yet motivated for IOP, but are motivated to be in group counseling. Group counseling is becoming something that is not available yet. We know it's the evidence-based practice. We know it's what works most for our patients, and it's an area that I hope, as we move into a new administration, that we have an opportunity to come back and fix. This is probably the top 1 or 2 areas that we think needs to be fixed from a rate perspective. I get the question a lot of what's the difference between TBS, CPST, PSR, and SUD case management. So this is a slide that gives you a lot of information, but really does the comparison. The biggest difference is who are the eligible providers. We've kind of talked about that already. The other challenge and thing to recognize is that for PSR, PSR is only face-to-face with the client. There is no phone call, there's no collateral contact if you're billing PSR. The other thing is that there are tiered rates for community-based services for TBS and PSR, but then they still, if it's office-based, then you have a lower rate. You also have the 90-minute limit before the rate drops to 50%. So that's something that is also. Crisis services. This would be the other thing in my top 2 that needs to be fixed from a policy perspective from a rate and payment issue. We have been told for 2 years there would be efforts to add some services, particularly to add a crisis urgent care and crisis stabilization. Unfortunately, we didn't do this before we changed our payment policy. So the issue is with the code set that was selected, you get 2.5 hours to solve a crisis. If you go beyond that, the only service code that's really available to you as a provider is CPST because you have licensed staff delivering the service. You can't bill individual therapy on the same day that you bill crisis service. So it becomes a real challenge. The other thing to be aware of if you're providing services in an emergency room, and I don't want to scare anybody because right now Medicaid policy is you can deliver a crisis service in the emergency room and they will pay you. I will tell you that that is not consistent with what's in the rule. We've got the policy statement in every training that the department has done. It's in the 401 training. It's in the 501 training. We've brought it to their attention. They know it's an issue. It's something we have to work through in the future. Here's the summary of the outpatient residential services or the SUD residential services. You'll see how they're organized. Again, you've got outpatient is level 1 and level 2, and then residential is level 3. You've got various levels under level 3. Making sure that if you're doing SUD services, you understand what withdrawal management services are. If you've not read Chapter 6 of the ASAM book, I encourage you to read it. If you don't own a copy of the ASAM guidelines and the ASAM book and you're doing SUD residential services, you need to own the book. Yes, it's available online, but if you read it online, it will refer to the book because what's online is not as complete as what's in the manual, in the published book itself. So I don't get any royalties from ASAM, but I'm just telling you from a provider perspective, you probably need to make sure you've got the book available. Level 2 ambulatory detox is an add-on. It can be extended. It's staffed by physicians and nurse practitioners that are readily available. You can also provide level 2 withdrawal management in an SUD residential treatment level of care. What they're saying and the way that they put this together, and it's confusing, is that essentially if you're doing withdrawal management and you've got a residential program, but you've got this person who's in actually level 2, maybe they're in IOP, maybe they're in PH, but they need that detox, you can provide it in that setting. So that's what the rules actually, that's what the provider manual says. The question we get is, what happened to subacute detox? We don't have that anymore. You do. It's withdrawal management. And it's moved into a residential arrangement, and you have it in level 3.2, and then you have it in level 3.7. 3.2 is what we refer to as kind of the social model of withdrawal management. So it is not staffed and supervised by nurses and doctors, but you have people who are implementing protocols developed by physicians and nurse practitioners. And you have access to physicians and nurse practitioners as needed. 3.7 is what we would have previously called residential detox. It is actually referred to in the manual as inpatient, but it is intended to be residential. But this is where you do have the higher level of staffing. You have more risk. It's the next level removed from true inpatient care. So just being sure you understand what those levels are and what the staffing requirements are. One of the most significant changes for the billing and finance staff is this is your new job, revenue cycle management. For many organizations, this is an entirely new skill set. It's an entirely new process. It's lots and lots of new information. One of the things you need to be completely focused on in your billing is timely filing limits. Through the end of this calendar year, All of the managed care plans have 180 days. You have 180 days to file claims. No longer 365 like you have under Medicaid. 180 days is what's the requirement. 2 of the plans still have 365 days. 3 of them do not. Starting January 1st, unless we are successful in a change in policy, you will start to follow what's in your contract for timely filing. For one plan, that's 90 days. For 2 other plans, their contract requirements are 120 days. That information is in the Managed Care Resource Guide that's posted on the BH Redesign website under the Billing tab. But you need to know what's in your contract. When you're doing revenue cycle management, that's going to be one of the most important things you need to do. Teresa already touched on some of the key points around revenue cycle management, but I want to walk through some of the forms and codes and the reports that are available in the EDI set, because these are new to many providers. We're now mostly using clearinghouses. That was a hurdle for many of us. It's been a challenge, but it's an important thing because it does give you some additional information. It does add cost. I am not in any way saying none of this adds cost, because we had a lot of administrative cost in doing some of this. Making sure that on the front end, when you submit a claim, you're checking to see what was accepted. Did you get a 997 or a 999 report that tells you these were your unclean claims? We got to track that. You got to work those claims. You may find that information's in a text file somewhere. You got to figure out from your clearinghouse, where do they send your unclean claims report? How do you get that information? How do you track that information? How do you fix those claims to get them back in? Once the claims are accepted, the 277 gives you the claims that were accepted by the plan. You also need to make sure you're looking at your 824. Because if you have a client who didn't have the right subscriber ID or the member number, they're getting rejected and they're not going to show up on your 835 anymore. They're going to be in a different place. So that's another report, making sure you understand that report, you're tracking it, you know what's available. Eligibility filing. Some of you are doing individual client by client. You can also use the 270, 271 batch eligibility reports. This is a service that most clearinghouses use. You can also go directly to each of the plans and do a direct trading partner agreement with some of them. Make sure you have the ability to do that so you know who's currently enrolled. Our clients move in and out of managed care plans, so we have to know who they're enrolled with and what they look like. Getting your admittance advice. I continue to hear many of you are still getting paper, and it's incredibly frustrating. You've got all 5 managed care plans here. If you're still getting paper RAs, talk to them about why you're getting paper RAs. You can and should have signed up for electronic ERA. Some of this is a function of the accelerated payment. And so because the payments are moving more quickly, there's a cost or time lag for adding electronic RA. But I believe we've moved to a point where you should be able to be getting those RAs electronically. So making sure that you're doing that. Full payment, making sure you understand the denial codes. Partial payments and reworking those processes. Reprocessing claims. The old days of rebilling claims through the way we did in MITS, it's different with managed care. It's a reprocessing. You can't just remove and rebill. It will deny as a duplicate. In the billing guide, the MCO resource guide, the billing tab, question 32, gives you each plan specific information for how you reprocess claims. Yep. In the billing guide, it's the billing guide tab. It's question 32. The MCO resource guide. That is on the BH Redesign website. So from the BH Redesign website, find the MCO resource guide, go to the billing tab, go to question 32. Oh, I forgot. Third-party insurance. Yes. So this is still a work in progress. I hear the sigh. So just know that with implementation, the Department of Medicaid, Mental Health Addiction Services, representatives of all the plans, the Ohio Council, a couple other stakeholder groups, we are meeting now every 2 weeks. We were meeting every week. And this issue is one that is on our agenda. We are trying to figure out what is happening with TPL. We know there's stale data. We know there's inconsistent data. We know you'll get told it's denied for TPL. You'll look at MITS and you'll see that that's a stale, outdated claim. You can call the plan that they supposedly had the coverage from and know that it's still not the right claim. It's still a work in progress. What I can tell you is there are many, many loops between what the plans do and what the department does, and it is not clear how we're getting to what is the one source of truth. So it's a work in progress. The other issue we're still working through is what do you do if that practitioner isn't covered? So if Anthem, Blue Cross Blue Shield, doesn't cover dependently licensed practitioners, what do I do? We don't have an answer to that question yet. Right now, the answer is, well, they have third-party coverage. If they don't cover dependents, then you have to find a right level of practitioner to provide the service. Do you understand what that does to access and capacity for our services? Do you understand that who we're mostly talking about are children, and many times we're talking about children who have lost a parent or are in child custody and are living with kin? So this is an issue that is still unsolved. It's one that we're continuing to work through. HR practices, all this practitioner enrollment stuff, it's got to be part of your front end and it's got to be part of your termination. And it's really making sure that you have a process for knowing when you're hiring people, do they have an NPI? Do they need to get an NPI? Have they already registered with Medicaid? Do you have to unaffiliate? Do you have to affiliate? What is the steps that you have to do through your HR practice, and who's responsible for that? Is it a billing function? Is it an HR function? Same thing on termination. When do we terminate their affiliation? Who's responsible for doing that affiliation? How do I make sure I get paid for claims for services delivered by that practitioner? Billing is based on data service. So as long as their active enrollment was a data service, you should be good. Can I keep going? Because I'm going to run out of time. I'm trying to manage my time here. Partnering with managed care. These are all resources. This is the link to the managed care resource guide that I've been talking about. It's on the BH Redesign website. You also want to know there is a standard authorization form that you can use with all 5 of the managed care plans. They worked really well together over a very long period of time to get all of their legal counsel to agree on a single form. That was an act of God, if you don't know that. And then making sure you understand and have access to the denial codes and the remittance advice codes. There are 4 phases of contracting. It's important that everybody understands. We talk about contracting and credentialing. There's 2 more steps that you need to make sure you are aware of. Because until you have their contract loaded with all of your practitioners, your contract isn't really complete. Quick question, how many of you have countersigned contracts back from all of the managed care plans? That's what I suspected. This is a concern going into the end of the calendar year, given that as of January 1, you will have to be a contracted provider in order to be paid by the managed care companies. It's concerning that we have a number of providers who do not yet have their countersigned contracts received back yet. I think it's a function of contract loading, because typically at a plan, until the contract is loaded and everything is complete, it's not released for signature. And we know that the whole NPI issues are big. It was a huge burden on the plans, and that's been a challenge. Transition of care, I've talked about these a bit. There are 4 things that were done to protect providers and consumers through the transition, and that is to make sure that as we put contracts in place, you had a 6 months allowance to do that. The timely filing was extended to 180 days. The managed care plans have to pay the fee-for-service rates for the first 12 months. They have to keep the same prior authorization requirements for 12 months. So this will take the payment rates, and the PA goes all the way through June 30th. Given where we are, and we get to some data here in a minute, I think these are things we need to be thinking about requesting an extension of, because I'm not sure that we're collectively as systems ready. The cash advance, the intent of the cash advance contingency plan was to sustain access and make sure that clients continue to get services, people continue to be paid. There was a 4-month advance offered at 54.6% based on calendar year 2016. Repayment was to begin in November. However, as we were looking at data and we were looking at claims payment, we realized that November was too soon. So if you accepted a cash advance, all of the plans are currently working with you to come up with an alternative payment arrangement. What we've been telling providers is this is an opportunity for you to negotiate. The expectation of the Department of Medicaid, the expectation of the Joint Medicaid Oversight Committee and the legislature was that plans and providers act as businesses and individually negotiate what the terms of the repayment should be. I've put the links. This information is also available on the BH Redesign website. Moving to value. Another question I get a lot. What's the outcomes going to be? What are we going to be expected to measure? Let's start with what the plans are going to get paid for. In the provider contract, and I've given you the link to this, this is posted on the Department of Medicaid's website. This contract is updated every 90 to 180 days. It's typically termed for the calendar year, or for the fiscal year. There are several appendix you want to pay attention to if you're thinking about outcomes, if you're thinking about what are they going to measure me on moving forward. Appendix K is your quality measures. That's where your quality care, that's where you'll find all of your case management expectations. M is the quality measures and standards. Paragraph O is what was previously pay for performance and now the quality withholding. In 2018 and before, it was a pay for performance. Now we've moved into quality withholding, and so it's 2% of their capitation rates being held in abeyance based on the outcome of quality measures. There are 4 areas that are indicated for quality measures: cardiovascular disease, chronic condition diabetes, behavioral health, and healthy children. That is defined in Appendix M of this contract. It is 287 pages of lovely reading. I recommend it if you can't sleep at night. It will put you to sleep. Here's what is the quality withholds for behavioral health. Not surprising: initiation and engagement of alcohol and other drug dependence treatment, 7-day follow-up after hospitalization for mental illness, and use of multiple concurrent antipsychotics in children and adolescents. There are more measures in behavioral health, but these are the 3 that are tied to quality withholding. I also included the chronic disease for diabetes, because you want to know how we improve care. The work that you all do every day impacts total cost of care. We know that in Ohio, when we looked at the Medicaid data, the top 100 high-cost patients who were connected to a community behavioral health organization compared to the top 100 high-cost patients not connected to a community behavioral health provider, the total cost of care was almost 5 times higher if they weren't connected to behavioral health. When you're providing behavioral health services, you are improving their overall health, their overall quality of life. If you understand that what we do is behavior change management, if you think about motivational interviewing and what we do, we're behaviorists. We do behavior change. If I'm managing diabetes, guess what I'm trying to do? I'm managing behavior. This is why integrated care, integrated behavioral health and primary care is so important. It's so important to our people who are dying 25 to 30 years younger because of their untreated health conditions or because their health conditions aren't being managed. So these are the measures. If you're not capturing this data in your electronic record, if you're not understanding what's going on there, you can help the managed care plans achieve their goals. They will want to partner with you if you can help them know that your people, the people you're serving, have gotten these services. This is how we get to value. This is how we make the case for what we do. How am I doing on time? Okay. Billing tips and challenges. The next few slides, I'm going to walk through what we're seeing. This shouldn't be a surprise. There will be lots of moans and groans in the room. I expect that. We do have a few things that we know. The number one issue that we continue to see pop up is rendering provider. Part of this is contract loading. Part of it is the MITS file correct? Part of it is in the data exchange between the plans and Medicaid on a monthly basis or every 2-week basis. Is the data getting overridden? We're still working through that. Every claim has to have an NPI. If you get denials for missing NPIs, it's important for you to go back and look at your originating file and find out if your originating file had an NPI on it. One of the things we know is that the plans are using a number of manual processes. So when you send a file in, claims are getting split. So if your file includes an individual therapy code, it includes a TBS code, it includes a day treatment code, an IOP code, those claims, when it comes in, will be split because there are manual processes for certain services. We're not sure that when that data is being split, that everything's properly transferring. And I say that because we know that for many providers, there are issues around how you put together and construct your claim. Are you putting the NPI in the header or the detail? Paramount can only accept a single NPI in a claim. You cannot put in their system, they were not part of MyCare. They didn't have to build the system the way that the rest of the plans did. So for their system, whether you put it in the header or the detail line, it doesn't matter. You can only use one. So if you've got a client who saw 3 different clinicians in the same day, you got to bill that to Paramount as 3 different claims. With the rest of the plans, it was very much our history, and again, this goes back to our legacy and how we build MCSIS. You would bill, and your primary focus was how many services did my client, Sally Ann, get in today? And you billed all those all those dates. Sometimes we didn't have to deal with NPI, so we put information in the header and we didn't think about it. To help your claims process, if you're billing multiple practitioners for the same client on a claim, don't put the NPI in the header. Make sure it's in the detail line. All of the plans have confirmed that that will help, particularly with this claim splitting issue. So just be aware of that. Duplicate billing. So there's kind of a couple issues. There's same-day services, and I know Sonda's going to cover NCCI edits this afternoon, so I'm not going to spend a lot of time with this. But you do need to be aware of the NCCI edits. You do need to be aware, if you're not familiar with the Medicaid NCCI edit table, you need to be. You need to understand what is allowed, where you can override and use an NCCI modifier. These are not the modifiers that we historically use. These are different. They're only used to override that NCCI modifier. HCPCS and rolling up. So this roll-up, there's a lot limited roll-up under this new model because everybody's billing with individual rendering NPIs. We've had some claims denying lately because you've got the same clinician delivering a service to a client. It may be the same service, but you've got different location codes. According to the roll-up logic, if the place of service is different, then it's 2 services, not 1. So we've had some issues with that of late, so just be aware that that's what's happening. The only place you'll find the logic for the roll-up is in the provider manual. Third-party liability in the Medicare COB, we've kind of talked about this, but this is some additional detail. Because the plans were told to construct their system based on what's in the provider manual, when we got into July and started getting claims denied at the end of July into August, we realized the managed care plans were not told to configure the TPL bypass for Medicare and for commercial insurance. So there's a whole form. The submitting other payer, the final instructions for Medicare and commercial insurance. There are overrides. If you don't have if you don't have a Medicare eligible practitioner delivering a Medicare eligible person, you can go directly to Medicaid or for a dual eligible patient. They are following a different rule in the Medicaid section. The managed care plans have their own rule for third-party liability. When we were working directly with Medicaid, they were referring to us to a rule in Chapter 5160.01. The plans rule is in 5160.26.09.1, something you might want to look at. We're going to have to continue to work through third-party liability. We're going to have to get better at understanding what other coverage people have and working at contracting. Here's another one with nursing. When you submit the ordering prescriber, there is a DK qualifier required. Most of your systems will be initially set up to default to a prescriber because it's thinking you're doing electronic prescribing. When you're sending this in as an ordering, you have to use the DK qualifier. Other common issues we're seeing is services being billed under the wrong provider type. So if you're a SUD, you've delivered an IOP service, but it gets billed under your mental health provider type 84, it's going to deny. Now, with some of the manual processing that's happening and the claim splitting, one of the things we're still trying to understand is, did your original file send the claim under the right provider type number? So if you're getting denials for provider type, check your originating file and make sure that when you initially billed it, that it was billed under the right one. We're still seeing issues with services being billed under the wrong contract or wrong fee schedule. So many times what we're seeing is EMM codes being paid at the medical rate versus the behavioral health rate. Or individual counseling services being billed at the medical services rate, not the behavioral health rate. Part of this is a loading issue. Part of it's the complexity, making sure we get people in there the right place. Provider specialty and wrong taxonomy, making sure you understand where people are. They are looking at provider taxonomies. So this is one thing else too, when you're billing. Making sure that you've looked at what is the taxonomy codes that are assigned in NPPS. So when a person is signed up for their NPI, what did they register under? Does that match what's in the Medicaid file, and does that match the information sent to the plan? The plans are independently checking all of that information, even though MITS has already done it. So there's a lot of duplication in this issue, and this is where we're seeing denials for taxonomy codes. We're seeing denials because we billed a residential service using an LSW. You can only bill an LSW, you can only bill under an independently licensed person for residential. So making sure you understand who's the required to bill the service. We're also starting to run into some issues where, and this is something we have to work through, we've not yet had the conversation with Medicaid, physicians. If I have an OBGYN billing a medication-assisted treatment service, is that allowed? By rule, yes. So we've just got to continue to work through some of these issues. Add-on codes, missing the base code. My favorite is we have the add-on code being paid, but the base code being denied. So there's lots of issues that we're still working through there. Diagnosis codes, making sure that when you're submitting diagnosis codes that you're using the proper number of digits. If it's a 4-digit code, you have to include the 0. You can't drop off digits. If you drop off digits based on what's on this document, you will not have the service paid. And my favorite, which is not in the administrative rule, but is in the provider manual, is you have to bill based on what are the place of service codes that are indicated in the provider manual. Prior authorization, I'm not going to spend a lot of time here because there's a lot of challenges. Many of our friends at the managed care plans are well aware of all of the concerns and challenges that we have with prior authorization. There's 2 important points I want to make. As a clinician delivering services, you need to request authorization for what's medically necessary. If you have a 30-day program, you shouldn't be sending 30 days for every single patient. It should be individualized to the need of the patient. You have a 12-week program, you're not requesting 12 weeks on every single patient. It's what's the individual needs of the patient. That's our obligation. That's medical necessity. That's the world we live in. Conversely, we expect the plans to do the same thing, that they should be authorizing plans based on what the individual needs and needs of that patient. We know that is not the case for a couple of the plans. This is an issue we're continuing to track. It's an issue we're working through. I will tell you right now that the Department of Medicaid is taking a hands-off approach. This is one of the primary functions that they believe they've purchased with moving to managed care. So we have to continue to work through the process. We have to do our part. Request the number of days that you believe is medically necessary for the patient that's presenting to you. Don't make it a uniform approach. It's got to be individually tailored to what's the needs of the patient. And we'll continue to work through this issue. You've already seen this slide. We'll make sure you get a hard copy of this. All of your billing staff who are working issues should have access to this information, and these should be their primary contacts. We've got a few. I'm at time. I'm going to keep going until I get told not. I want to share some data.
We do have a number of questions.
Okay.
My phone is blowing up. I'm going to hit the people in the room, so we just need to make sure.
Okay. I want to go through some quick data. We all have the shared goal of this being successful, so I just want to make sure that that is clearly understood. The Ohio Council has been very clear that we are partners in this. We all need to work together. We need to be successful because our patients depend on us every single day. This is some data. So how did we do January to June with the transition? What you see is a 6-month accounting for how Medicaid expenditures were going in community behavioral health. We have asked for the Department of Medicaid to provide additional data because what you see is with the implementation of the coding changes, you see a $98 million reduction in the expenditures for community behavioral health. I think that's a function of the service, some of the service changes, particularly counseling, crisis, group, ACT. But we have a challenge, and we continue to hear, well, it's because the Medicaid rolls dropped. I don't think that accounts. We've not been given information that says that the number of people using behavioral health services dropped significantly. We also know that the outpatient hospital programs could start delivering some behavioral health services, but not to this tune. This is a comparison of reimbursement since we've moved into managed care. So what you see in green is what was billed in 2017. What you see in blue is what was paid by the managed care companies in July, August, and September. This is why the cash advance was so important. This is the concern we have with the cash advance ending, because the October numbers, which we just received, are better. They were $74 million. But if you understand that this is a $1.2 billion benefit, you would expect to see $100 million being billed every single month. And we hit $23 million in July, 61 in August, and 64 in September. You can't even see this slide. But this is what the managed care plans are reporting out. And this is the August number because it was the most accurate at the time that we had, and we had $61 million. We had 765,885 claims. That was what was reported and paid, with about an 84% payment rate of claims submitted. So I shared this because we're tracking this information. This is the report that we're looking at with the Department of Medicaid and the managed care plans every month. Oops. The Ohio Council did a survey of our members. We had a 50% response rate. That's unheard of. By the way, anybody who does surveys, a 50% response rate is unheard of. This was the first 90 days. We gave folks really about 4 days to respond to the survey. And what we found is that our members said about 55% of their claims were actually being paid. So the AR and the total claims payment are almost the same, and this is 72 organizations who reported submitting over 1 million claims. This is what it looks like when you put the AR compared to payment. That is not a system that's stable. That's a system that is at very significant financial risk. We've got to get this back to where we were. When I've looked at data and I've asked people in the last 4 or 5 days, what's your AR compared to where it was in September, at September 30th a year ago? For every single organization, it's been at least 3 times more. This is one that is still the vexing issue for me, which is claims payment, the number of claims. What you see in green is the number of claims that these 72 providers reported that they submitted. The blue line is the total number of claims in the first 90 days that each managed care plan reported processing. It is statistically improbable that 72 organizations reported sending 1 million claims and the plans reported accepting and repaying, processing or pending 1.7 million claims. So we're still trying to figure out what's happening to claims, because I think that's a function of why providers believe they have so much more AR compared to what the plans are saying. And this is not in any way disparaging the plans. I think we've got a problem that we don't know where claims are going. They don't know where claims are going, and we've got to collectively figure out a process to figure out where those claims are. Because until we solve this, I can't solve the AR problem. You all can't solve your AR problem. So the next steps, we've talked about all of this already. It really is looking at what can we do to be successful in claims payment. I think we have to extend the transition of care requirements. We need to look at continuing to revisit the payment policies, streamline and standardizing process, particularly around NPIs and TPL. And then we've got issues that are going to come up related to SUD residential and the 1115 waiver that's under development. And then what happens with behavioral health care coordination when that moves online, which is currently slated for July of next year. And this is my last slide, which is what can you do? We had an election last night, in case anybody was noticed that. I don't know if it was on your TV, it was on mine. So we're going to have a new governor, we're going to have a new administration, we're going to have new people. Most of these folks are already elected office holders. This is your opportunity to reach out to them. Let them know what's happening in your organization. Talk to them about the business impact. Talk to them about how we can work together to make this successful. But let them know your story, because this is where we're going to get the type of impact that we need to make the changes that we know are necessary to make this work. And I've given you the link here on what you have to find your current elected officials.